If you are over 50, I regret to tell you that there is a 50% chance that you have an enlarged prostate. It's like tossing a coin. If it's heads, you have an enlarged prostate. If it's tails, your prostate is normal. But what I want to tell you in this video is that most men will not need medication or surgery to treat an enlarged prostate. Hello, I'm Dr. Tiago, and I'm a urologist here in São Paulo. Benign prostatic hyperplasia is an extremely common disease. This is statistical. 50% of men, that is half of men at 50 years of age, may have the problem. And this statistic can reach up to 80% in men over 70, 80 years of age. I'm sure you must know someone who has a prostate problem, or if you yourself don't already have the problem and are undergoing some type of treatment. But what is benign prostatic hyperplasia? Popularly, people call it a swollen prostate. I don't like this term swollen because the term swelling gives it a connotation of being something temporary. If you have an inflammation in your throat, you see your throat, it is swollen, the inflammation has passed, the swelling reduces, the throat returns to its normal size. This is not what happens in benign prostatic hyperplasia. In benign prostatic hyperplasia, there is an increase in the entire gland. The prostate is about the size of a lemon. It weighs around 20 to 30 gris on average. From the age of 40, 50, there begins to be a global growth of the prostate, of the entire gland. And then it can go from 40, 50, 60, 200. There are even reports of up to 500 gris of prostate, which is extremely large. I would like to clarify that benign prostatic hyperplasia does not turn into prostate cancer and does not increase the chance of you having prostate cancer. Prostate cancer is a separate disease. Hyperplasia and cancer can even exist at the same time. So we always need to investigate both diseases in men. When we screen for prostate problems, we are actually screening for prostate cancer and benign prostatic hyperplasia, okay? So that already clears up that doubt that you probably already have. Many men ask me here, Doctor, if I do nothing, is there a risk of this becoming something more serious? No. If you have hyperplasia, your chance of having prostate cancer is the same as if you did not have benign prostatic hyperplasia. So why does the prostate grow? That question is a bit more complex because science hasn't yet fully understood all the factors involved. However, it is related to hormonal changes that come with aging, such as a reduction in testosterone levels combined with a maintenance of dihydrotestosterone levels, which is another male hormone. It's also related to estradiol levels. It's linked to inflammatory processes that occur in the gland as we age, and also to genetic factors. We know that those with family members who have hyperplasia also have a higher chance of developing benign prostatic hyperplasia. And that brings us to the question of treatment. I see patients at the Einstein Checkup Center, and it's very common during routine exams for men over 40 or 50 to find out they have an enlarged prostate on a routine ultrasound. So does that mean we should start some kind of treatment? Not necessarily. There's a very simple guide we can use to determine whether or not a patient needs treatment. There are two initial simple questions that you can answer right now in your head. The first one is, does the patient have symptoms, and are these symptoms compromising their quality of life? Yes or no? Second question, are there any complications related to benign prostatic hyperplasia on the imaging tests? Yes or no? If your answer to either of these questions, the first or the second, is yes, then you are indeed a candidate for treatment, and we'll talk about what that treatment is, whether it's medication or surgery, in a moment. Because first, I want to comment, I mentioned the complication on imaging tests. What are these complications? During routine exams, besides the size, we assess if there's any degree of impairment in other organs due to benign prostatic hyperplasia. The first commonly found complication is what we call post-void residual. If this patient has no symptoms, but they have a persistently high post-void residual, that is a complication of benign prostatic hyperplasia. If this patient has what we call a stress bladder, which is a thickened, or to use the ultrasound term, trabeculated bladder, then that also indicates the need for some kind of treatment. Other alterations include possible kidney dilation from significant urinary retention during urination. But usually this patient ends up having symptoms. So the answer to question one is usually yes in these cases, okay? So that's basically it. If you have symptoms that are compromising your quality of life, or if you have these alterations on your imaging tests, then you are indeed a candidate for treatment. Notice that at no point did I talk about the size of the prostate. The size of the prostate is a factor to be considered, but it's not the main factor. Many men ask, doctor, at what prostate size do we need to start medication? It's not the size of the prostate that indicates medication or surgery. What indicates some type of treatment are those two questions I asked. Has symptoms or has complications on the tests? Okay, the answer was yes to one of the two questions. Now, what treatment do we recommend? Then we move on to a third question. Is there any absolute indication for surgery? If it's yes, this patient goes to surgery. If it's no, they can go for medication-based treatment, okay? And what are the absolute indications for surgery? The first one is a bit obvious. It's what we call urinary retention. This patient can't urinate, they need a catheter. Obviously, we'll only be able to get this patient to urinate through surgical treatment. Second, persistently elevated post-void residual. I mentioned to you that if there's a residual, usually above 100, 150 milliliters on the ultrasound, and I say persistently because often you do an ultrasound once, and we know that the routine for performing an ultrasound isn't ideal from the perspective that sometimes patients fill their bladder more. They take a long time to be called. The ultrasound is delayed, and so it ends up not reflecting the patient's daily life. So we repeat the ultrasound, and they still have this increased residual. In that case, for this patient, the ideal might be to go straight to surgical treatment. Stress urinary incontinence, okay? It's an indication that usually leads us to start recommending surgical treatment for this patient. Or if they have renal impairment, like urinary tract infections, kidney stones, bladder stones due to benign prostatic hyperplasia, this patient should also be referred for surgical treatment, which usually involves scraping, well, all the treatments I've already discussed in other videos here on the channel. If you don't have any absolute indication for surgery, but your doctor, your urologist, talked with you and he recommended surgical treatment, then we get into what we call relative indications for surgical treatment. What is this relative indication? The relative indication is one where during the conversation, I and the patient, the doctor and the patient jointly decide on a surgical treatment, okay? This includes cases where the patient isn't tolerating the medication, meaning you need treatment, but the side effects of the medications end up being more significant than the benefit of the medication itself. This patient ends up having to go for a definitive treatment, which is surgery. Or you're symptomatic, you don't have side effects, but the medications aren't working as well as we'd like. The medication doesn't have a 100% efficacy, unfortunately. So we also end up progressing the treatment and moving on to surgical treatments. Or there are some patients who don't want to take medication. They don't like it, for personal reasons, matters of values. Prostate medications are a bit expensive, and so they opt for a more definitive surgical treatment. That's also an indication for surgery. These are very acceptable indications that resolve the problem. But if you say, doctor, I don't like the idea of surgery, I'm scared, I don't want any surgical treatment, what medication do we start with? This is a slightly longer topic. I have a video exclusively on the channel where I talk about this, and I'll leave the link at the end for you to watch. But there are two main groups of medications for the treatment of benign prostatic hyperplasia. One group is more for symptoms, which includes tamsulosin and doxazosin. These are medications that relax the prostate's muscles and improve flow, thus improving urinary symptoms, but they don't change the size of the prostate. And then we have finasteride and dutasteride, which are medications that act on that issue of testosterone and dihydrotestosterone, which I mentioned at the beginning of the video regarding the cause of hyperplasia. And these can indeed inhibit growth and, in some cases, reduce the prostate size by around 20 to 30%. But they are generally medications for continuous use, okay? So I talk more about these two medications in that specific video. Often we need to use both in combination, right? Therefore, the message I'd like you to take from this video is most men will not need treatment, whether it's medication-based or surgical, because despite this growth, it's a growth that doesn't change a man's life at all and doesn't affect the urinary function at all, causing no type of complication. The important thing is if you've detected this hyperplasia and you're doing well, always maintain follow-up with your urologist. Deal? I hope this was clear for you. Leave a comment below if you have any questions. Don't forget to like the video and subscribe to the channel. This is very important so I can continue bringing this type of content to you and so that this information reaches the largest number of men out there who need it. I'm Dr. Tiago, and see you in the next video.